It's so exciting to have these in active research trials already, the gene transfer approaches, but of course, we're already thinking, how can we do this better now that we're using these research trial approaches? One issue, of course, is tissue penetrance and making sure that we maximize the amount of transgene that gets to the myonuclei where it needs to be. The theory, of course, is that muscle is a syncytial tissue, and so there's multiple nuclei in every muscle fiber. If you get transgene into a muscle fiber, is that sufficient for the entire fiber that one transgene can make dystrophin, or do you need multiple transgene copies to be in each muscle fiber? And if so, geographically, how far apart do they need to be to make sure that the entire muscle fiber has good integrity? If it doesn't, it's still going to be leaky and is going to have issues with potentially losing that transgene over time, in terms, or being damaged to the point where it's lost and replaced by fibrotic tissue, where you're back where you started from with this disease in terms of the natural progression. Some of this work was looking at different types of viral delivery and whether they might potentially be more efficacious, or pairing it with other delivery mechanisms to make sure that it gets specifically to muscle tissue where it needs to be, not just skeletal muscle, but also pulmonary muscle, and then also cardiac muscle, and making sure that that expression is stable, but also minimizes the toxicity of getting it where we don't want it, like the liver and the kidney and other places that are going to be impacted by treatment and have complications if they're over inflamed related to the process. One thing a lot of people in the community are really hopeful about is, could we target the central nervous system? Because of course, a good proportion of our patients with Duchenne have autism, anxiety, ADHD, other cognitive issues related to their disease. It does not seem very hopeful that what we're doing right now with the systemic delivery is going to have a massive impact there, because there's issues with blood-brain barrier permeability, and then also how these things actually work centrally may not impact these kind of phenotypes very well. But perhaps that's somewhere that we can think about going in the future. We also do have the hope that we're going to be able to treat people as young as possible with this disorder. And with the delandistrogene moxeparvovec program, the one sponsored by Sarepta, they have already gone to earlier dosing younger than 4 years of age, which was the cutoff for the original research trial. The Pfizer program also has planned a early onset cohort that's going to be starting getting dosed in the United States very soon, in late 2022 is the hope. If we do get newborn screening into our armamentarium for Duchenne, identify people very early, would it be appropriate to treat them immediately with one of these approaches, or do we need to wait for a sweet spot in terms of when they're experiencing their disease for when we're going to get the maximal impact, but still have the durability that somebody needs to live as long a functional life as possible with Duchenne muscular dystrophy? And then putting aside gene transfer as a concept as a whole, we also have to think about other approaches that are on the horizon that might be even more tantalizing, whether it be using 2 viral vectors at once to deliver different pieces of dystrophin so that you can get even more of the entire gene delivered to make more functional full-length dystrophin protein for the person, or whether you use an approach such as gene editing, which is the CRISPR-Cas9 approach that has gotten so much buzz over the years. There were preclinical posters about correcting various kinds of mutations in dystrophinopathy with CRISPR-Cas9.